Welcome to the National Cancer Prevention Workshop presented by Less Cancer. My name is Lance Gould, and I'm the CEO of Brooklyn Story Lab, a media firm that works with purpose-driven organizations and teaches them how to create content to better amplify their work in the social good space. Thank you to Less Cancer for staging this event and for inviting me. And today I'm pleased to introduce Professor Miklos Fogarasi, Associate Professor of Medicine at Frank H. Netter, MD School of Medicine at Quinnipiac University in Connecticut. Welcome, Professor.
Thank you, Lance. It's a pleasure to be here. And thanks for the organizers of Less Cancer and Bill Cousins for inviting me. Appreciate it.
Excellent. No, it's really great. It's really great to have you and to be speaking with you today. And you've created this wonderful program. And to give the audience a little bit of context, let me just back up one sec here. The moment a patient receives the news that he or she has cancer, they start a journey that can be terrifying, and not just in medical terms. There are a huge number of decisions, costs, procedures, and consequences that can overwhelm most patients. And most often, the person delivering that news to the patient is a doctor. But how prepared is the doctor to help the patient navigate this arduous journey ahead? And can some of these specialized issues be handled from a primary care point of view? Dr. Fogarasi has come up with a potentially game-changing idea to help address this issue, a medical school class called Cancer Survivorship. Doctor, please tell us about this class.
Cancer survivorship is increasingly realized to be an important topic in terms of chronic disease management. With the increasing survival from cancer and cardiovascular diseases due to our improved technologies, and with improving life expectancy, we see more and more people surviving. But these people survive the acute phase of cancer and continue to live on with some consequences. Many of these are managed in the primary care office, some of them in the specialist office. What we decided to do is to create a class in medical school that's a semester long for electively signing up students to review the most pertinent survivorship issues, increase their confidence level going forward.
Excellent. Well, you mentioned that life expectancy has grown, of course, and that the advances that medicine has made in battling cancer has really led to some remarkable statistics. There are over 17 million survivors in the U.S., and this number is expected to exceed 21 million by 2030. Tell us about some other advances and what consequences that success has had on both patients and on the medical community with people surviving longer.
What we're realizing now is that surviving cancer alone is not enough. Quantity of remaining years is not enough. There certainly is set of pertinent and rather complex qualitative issues. And so Dr. Larissa Nekudov and her colleagues from the Brigham published a couple of years ago a paper proposing a new quality of survivorship care framework, realizing that both individual issues and structural issues of taking care of survivors are increasingly important. In fact, I would take the risk and say perhaps a new discipline of survivorship is evolving within the already complex field of oncology.
And when you mentioned Brigham, I assume that's Brigham Women's in Boston, right?
That's correct. We are associated with Harvard Medical School.
Excellent. Tell us about the silver tsunami.
Sure. So this is a term that was first, to my knowledge, used in 2013, describing that our aging society should anticipate increasing needs for mental health services and providers. But by 2016, 2017, more and more papers started to raise the issue that the increasing longevity coupled with cancer will change how the proportion of survivors can be looked at. Already earlier, we had half of the survivors at age 65 or older. But the prediction is that by 2040, this number will rise to more than 70% of our cancer survivors being over 65. And so with that 7 out of 10 number, there's a need for people who already have their comorbidities, their other non-cancerous long-term issues. This can cause the aging or graying of our society, can really cause a medical tsunami unless we anticipate complex healthcare needs, taking care of cancer in patients with increasing comorbidities. There are more clinical trials needed. more manpower, more specialty services, and more training for both general and specialist level physicians.
It's so fascinating to look holistically at the societal implications of medicine, healthcare, and to look down the road. Things are changing ever so quickly now with the pandemic and things of that nature, and it's just fascinating to see, to talk about, say, the silver tsunami, and what we've talked about so far is just really the general increase in life expectancy and the unintended consequences that has on society. It's really fascinating. Who are the students who are signing up for this class, for the cancer survivorship? Is there a common denominator among the students?
Our medical school at Quinnipiac has a general lecture on survivorship inserted into the second year curriculum, which is for all students. We decided to go beyond that and develop this elective, which takes on average about 8 to 12 students a year. They're signing up. There's a waiting list even now. And we limit the number because of the intimacy of the discussion we hope to create around these very sensitive issues. So this means that students sometimes come with their background from a gap year research or undergraduate research already in cancer. Others have developed an interest in cancer. Again, others have either a family history or friends or sometimes even themselves with a history of cancer and just are more attracted to this. But what connects these students is that they realize that cancer is a chronic disease that will be prevalent in their future practice, and they are interested in learning more about this. Now, one of the interesting things we started to do from the beginning is we take on additional students from undergrad level from the School of Health Sciences at Quinnipiac. And this allows them to take a peek into what a medical school course might be, but it also adds a very interesting interprofessional dynamics. Their questions sometimes come from a different angle. So 10, 12 students, a few of them from health sciences, mostly medical students though.
Well, you mentioned that you give undergraduates a peek at the class. Can you give us a peek at the class and take us through a typical classroom experience in cancer survivorship? The guest speakers the students would meet, the work they would be expected to do, things of that nature.
Yeah, sure. So this is an afternoon class on Thursday afternoons for about 2.5 hours. We get together about 14, 15 times in a semester. You can think about it as a Thursday afternoon club, so to speak. Mm-hmm. It's taught in a Socratean mode. So we discuss, we sit, we bring up issues, and I'm deeply interested in how students' opinions and concepts are evolving. Each session is typically managed by a co-facilitator and myself. So I bring on both actual survivors or members of our health professions, not just physicians, but also a social worker, a geneticist, a palliative care nurse, maybe a nurse navigator. So students get an idea that this takes a team to do survivorship care well. Besides the weekly topics, which starts with general topics, we also teach them certain skills, how to read statistics, how to break bad news, how to decide someone's priorities towards the end of life, and how to manage financial issues. So we have a set of topics following the American Society of Clinical Oncology survivorship guidelines and a set of skills that we hope these students practice.
You mentioned how to break bad news as one of the topic areas that you cover. Do you remember the very first time that you broke bad news to a patient and what that was like for you?
I don't know the very first time, but I do remember the set of first times. So, there's just an awful lot of anxiety and stress, and you probably do it the wrong way for many different reasons initially. And I would say this is an art that one would cultivate for the rest of his or her professional life. Certainly, creating a setup, creating the environment, creating the time to be able to do this well, inviting the right participants, not just the patient, but family, and also on my end, not just myself, but my social worker. Sometimes, people who talk about hereditary cancer better than I do. So it takes a team, it takes a location, it takes time. I need to know the case, and we need to be able to formulate a plan as a team. I certainly will have the options to offer, but I'm very much interested in what my patients and their family have to say.
Mm. Thank you for sharing that. I'm sure that it can never be easy to do that. What are some of the course objectives beyond preparing students to help patients navigate the complexities of a cancer diagnosis? What are some of the course objectives beyond that?
Right. So we are hoping to instill in our students an interest towards the complexities of care, rather than shying away from a list of issues that a survivor may present with, trying to understand them, trying to relate to them, trying to embrace them, trying to create an individualized set of parameters that define that particular person's survivorship journey. It's one thing to finish the acute chemotherapy or having had surgery and radiation, but what we find sometimes inviting our survivors is that the years after finishing the acute treatment can be just as complex, or some points even more complex. So our objective is to give a framework for our students in which to think. Think about prevention, think about surveillance, think about comorbidities, think about genetic and social and psychological issues, and how to coordinate all this care. We're trying to be practical. In fact, our goal is to create assignments even during the class that would bring our students closer and closer to do it in practice in the near future.
And just thinking about the students themselves, the students are human, and this is obviously it's very difficult to track or predict human behavior when it comes to this sort of thing. Are there certain people who are wonderful doctors, but that you've seen in this class, and I'm not looking for names, of course, but who just don't have what it takes to have that bedside manner? They just can't make that happen, make that human connection?
Let me step back for a second. We've been doing this class for 6 years now, and certainly that means 6 groups of students. That's about 70 students who went through this class. And definitely there are wide variations. Some of them come with a big heart already. Some of them come with more logical skills, but everyone can improve. A special challenge last year was to have this class on Zoom. Having the interaction about these topics through the camera of a laptop taught me that while it's easy to deliver knowledge and facts and statistics, it's a lot more difficult to develop behavior or attitude or skills of interpersonal relationships. Now, fortunately, this year we came back to our roundtable, so to speak, and I can tell you that no matter what level of skills the students come in, they all tend to get more confident to talk about these. We asked them at the end of the semester survey, and they seem to be doing quite well and improving in their confidence and techniques.
It's interesting to see making that human connection is even more difficult in this pandemic age, of course. You were born in Hungary, where you got your medical degree in 1989 at Semmelweis University in Budapest. And then you came to the US, worked as a postdoc, and completed an internal medicine residency at UMass before settling in Connecticut, where you did a hematology oncology fellowship at Yale. Are there any insights you have from your time in Europe? Does the US have a different approach to navigating life-threatening illnesses like cancer?
One thing I find is that students here are very receptive and perhaps don't hear enough of the little stories, of the little man stories, of the emotions, perhaps watching out for the cultural background, for the historical terms, of what it means to really have an individual's story come together. On the other hand, coming over here, people talk about cancer a lot more easily. There is no shame as much as where I grew up. There is no reason to hide the diagnosis. It's more of a scientific challenge, if you will. A team of people come together. It's not an individual, I'm struggling with this by myself. It's your physician and your physician's team and a very large group of people supporting. As an oncologist attending my first Survivors Day celebration, which are held in late spring across the US, I was very much surprised how openly people were wearing their button with the name of their cancer and the number of years, how long they have survived. This was almost a culture shock, so to speak, to me in survivorship, that you can bring it out to the open, and it's probably better to bring it out to the open, discuss this. And looking at the complexities, I think that the US, by pursuing survivorship as perhaps a new branch of oncology, is doing something very important, very massive. The predicted numbers of survivors will be around over 20 million by 2030 in this country. So we have a very prevalent condition, if you will, of survivorship.
Interesting. It's interesting to see how the difference culturally between U.S. and Europe. I imagine that Americans are very open to sharing things about themselves, and whether it's on T-shirts or other things and buttons. It doesn't surprise me to see that that's a more open American quality. Not necessarily. It's just an interesting difference between that and Europe culturally.
I would only speak for my small experience here in New England, and it might be completely different elsewhere, but certainly there's something enabling, empowering to be able to talk about this more openly and gather a team who will take it on as a challenge. I love that approach. Interesting.
Is this the only class of its kind that you know about in medical schools?
So survivorship is increasingly important, and you see it. Survivorship questions are coming up now on boards for board exams. You certainly see it at the CME level. So attendings are being taught about this. At the graduate medical education level, I'm aware of a number of residencies teaching it, whether it's a half-a-day workshop or whether it's a set of lectures. A self-standing elective that a medical school does is somewhat of a luxury, I would say, in graduate education. So here in undergrad medical education, in medical school, I think we're doing something, or we're experimenting with something that may be a bit ahead of other places. Again, I humbly just add that we don't take the entire class. We really take about 10-15% of our class with this intense approach. But I look forward to perhaps linking a medical school approach like this to a more organized approach in a residency. So hopefully this will continue to grow.
Well, speaking of school, the context of school, how do these students actually internalize these skills? And are there metrics to grade them? Or is it more about giving them an experience to prepare them for the field?
Sure. So trying to assess of how they come in, we have a pre-class survey where we ask them, what are your goals? What is your level of comfort in talking about cancer? These are second-year medical students who, by the time of joining us, had a longitudinal primary care clinic for over a year. So they have met some of these patients, some of the active cancer patients or survivors in the practice. Now, we asked them again, what is your comfort level afterwards? What would you do? Who would you team up with? So we're certainly trying to tap into the evolving sense of, yeah, this is a multi-professional and an interprofessional topic. In 2017, and also with this year's class, we tried something else also. I'm asking students to draw sort of an algorithm, we call it a concept map, of what they think cancer is doing to one's life. And they draw it at the beginning of class, and the maps are varied in their complexity. And as we go ahead in the 14, 15 weeks, we ask them to repeat. And so we create essentially a series of concept maps by week 4 and 8, and then towards the end. And it's heartening to see how thoughts become not just more complex, but also better organized. our students are able to think about the physical effect of cancer, whether it's late effects or long-term effects, the psychological effects, the spiritual effect, and the social effects of survivorship. In fact, this is a model first popular by publications from City of Hope, a wonderful cancer institution. And so following this model, I think we are building through the concept maps an understanding in our students' head that may lead to a more holistic level of care, seeing across the domains of survivorship and evolving that over 14, 15 weeks allows us to visualize of what our students now think at the conclusion of the class. It's incredibly exciting to watch those maps. I would add that the final assignment is we bring real survivors that our students haven't met yet and ask them to do an interview one-on-one. Now, this is not a medical interview, simple medical interview. This is a survivorship interview, at the end of which the students should put together a survivorship care plan and a treatment summary. And then we ask them to map it out. What do you think of that patient as a holistic, as a person who has the issues of jobs, the issues of family relationships, of interrupted education, of maybe financial toxicity, besides getting the neuropathy from chemo. So seeing across this is one of the ways of measuring how much we were hopefully building their knowledge.
And it must be very satisfying to see that as well. On the class syllabi for cancer survivorship, I see that the school requires all students to be vaccinated and that masks must be worn in class. I lost my brother to lymphoma a number of years ago. And when I was visiting him in the hospital, mask wearing was required to protect him and other patients. It seems fairly logical, and it shouldn't seem to be controversial to wear masks. How do you respond? How have you and the Netter School of Medicine navigated the mask question during the pandemic?
Sure. We are fortunate to have a strong leadership effort here, both at the medical school and then across all schools of Quinnipiac, that came up very quickly with unified approach. There is a mask mandate, there's social distancing. I would say 95% of the faculty and students are vaccinated. There are very good and well-planned return to campus guidelines. And while we had to pivot to Zoom teaching in 2021, I'm very happy to say that this past fall semester, from August to December, we were all in person following these rules. You know, I would do anything I can to teach in person. Knowing the difference of talking on Zoom versus being in the same room with someone, I guess we are lucky enough here to have a well-functioning system.
That's wonderful. Well, thank you so much, Miklos, for spending time with us today and for sharing your brilliant work with us. It really is a game changer.
Thank you so much for inviting me. I'm happy to contact with people. Again, as I said, I'm interested. I'm happy to share the curriculum, the syllabus, anything we can do to help the survivorship issues of our society.
Wonderful. And thanks again to Less Cancer for having me and Brooklyn Story Lab be a part of this initiative. Thanks again.
Thank you so much for Less Cancer. And I'm looking forward to other presentation on the workshop. Thank you.